presenter, Professor Nuzhat Chowdhury. She is a professor of vitreous retina of Bangabandhu Sheikh Mujib Medical University. After this presentation, we can take few cases if our chairperson permits. Then we'll finish our session. Professor Nuzhat Chowdhury, please.
This one. Honorable Chairperson of the session, Co-Chair, Moderator, and respected audience, first and foremost, I'd like to thank Ophthalmological Society of Bangladesh and All India Ophthalmological Society for giving me this chance to present my presentation here today. For retina specialists and their patients, intractable macular edema is a headache and a heartache. How many do you give? When is the end point? How long it will continue? When to switch? When not to switch? To what do we switch? Is it laser? Is it AIOC2022? Is it intraocular steroid implant? What to do? So what is the right foot forward in each patient? What do the studies say? So laser has always been the more prominent tool for treating the retinal disease until the anti-VEGF injections came. And the paradigm has now shifted towards in favor of the anti-VEGF. But is the time for laser over? It certainly is not, and that is what the studies say. In case of diabetic retinopathy study and for ETDRS, it clearly demonstrated the benefit of laser therapy, not only in diabetic macular edema, but laser is actually indicated in a lot of retinal vascular diseases, even in case of small children, like in retinopathy of prematurity. But we do consider the macular edema, the clinically significant macular edema in most of the cases where the embarrassment for us and the heartache for the patient is most prominent. So we would like to consider that first. So the efficacy of PRP was established like decades back when ETDRS and DRS studies came. Protocol S of Diabetic Retinopathy Clinical Research Network, drcr.net, found that anti-VEGF monotherapy is as effective as conventional PRP. But we must remember that the VEGF costs money, and it is an intraocular procedure with significant amount of stress for the patient. Prior to this anti-VEGF treatment, macular laser therapy was the mainstay. There was grid laser, and even for CSME, we used to depend on the laser. Since the publication of ETDRS in 1985, for 3 decades, it was the mainstay of the treatment. But as we all know that it not only decreases vision, in very few, only 3% of the patient can actually have any improvement, almost insignificant. So actually there is a decrease in vision for the macular edema, but there is no improvement of vision when you do the laser for CSME. So you see, sometimes you can see that the laser actually burns, and you lose the vision in that case. So laser treatment not only loses that functionality, it can lead to complications like choroidal neovascularization, visual field loss, decreased night vision, and fibrosis. So, as I have already said, that only 3% of the patients actually have any visual improvement, and the progressive expansion of the photothermal scars into the fovea or near to the fovea may actually affect the vision, especially in case of younger people. So we must be very aware of lasers. And when we consider, if you move on from diabetic macular edema to wet AMD, in pre-1980 there was no treatment actually. Then came the lasers, the thermal lasers, and then came the photodynamic therapy with vertiporfin, which became the main treatment for a long time until, of course, when the anti-VEGF therapy has come. And for the wet AMD patients, it has come as a magic treatment. So what is the treatment modality today? If we can see that anti-VEGF therapy does show reduction in blindness incidence when we introduce anti-VEGF therapy, it not only decreases the blindness, it actually increases the number of lines, number of letters that the patient can read. So it improves vision. So early pivotal trials showed that significant visual gains with monthly ranibizumab is possible. The MARINA-1, the Anchor, the MARINA and Anchor, these studies definitely show that ranibizumab increases the visual gain. The RESTOR also shows that the visual outcome with laser is actually inferior compared to ranibizumab. So the superiority of the ranibizumab actually was established by the RESTOR studies. DRCR.net et al. Compared laser, ranibizumab and triamcinolone. If you can see the graph, you'll see that ranibizumab with deferred laser gave the best possible visual outcome by the later months. So laser therapy is obviously a treatment of choice for the macular edema, but when you have extrafoveal edema, we can go for laser, but we do know that not only the number of injection is an issue, the economic burden is an issue, but we can also see that in a significant number of patients, like 40% of patients, we know that protocol I has analyzed that 40% of patients will have persistent diabetic macular edema. So there are a lot of new drugs coming up. We have been using ranibizumab and unlicensed bevacizumab and aflibercept. Now the brolucizumab has come recently. In one of our BVRS study, Dr. Niyaz Abdur Rahman showed a case where he has given 23 injections. After that, one injection of brolucizumab actually increased the visual acuity and decreased the macular edema. So it is effective. But as I said, that the reason for switching, as you can see, insufficient fluid resolution, 62.7% cases. So 40% of the patients that we treat will have persistent diabetic macular edema. So in that case, what to do? We can go for focal laser for the leaking microaneurysms. Some surgeons do advocate the modified grid still. We can always opt for the steroid implant like Ozurdex. So what to do and when to do it should be catered to the patient's need. So in conclusion, anti-VEGF therapy in center involvement diabetic macular edema is the treatment of choice now. Focal laser is useful in case of extrafoveal edema. It also, laser can help reduce the repeated anti-VEGF injection, reduce the burden on the patient and the healthcare system. But because the subthreshold laser safety and repeatability and its use in retinal vascular disorder continues to be vital because of its safety and repeatability. Its specific role alone and in treatment algorithms with anti-VEGF and steroid treatment continue to be elucidated. We need to have more research into this algorithm where when we use anti-VEGF and how far we go and when to incorporate laser and when to go for the intravitreal Ozurdex implant. So other modalities like dexamethasone intravitreal implant are effective options also, but not all patients will be responding to the anti-VEGF therapy. So the alternates are very important, and it will also, as I am mentioning repeatedly, that it will ease the treatment burden of frequent injections. So more trials and more studies